All right. Welcome everyone back to another virtual shadowing session at Hearts for Health. We're glad that you could join us on this Thursday evening. Today, we're joined by Dr. Yung. She's accompanied by a med student. And just to give you a quick background on Dr. Yung, she is an ophthalmologist specializing in cataract surgery. She practices in California. She'll be talking a little more about the specialty. And we do have a few questions along the way. So for any questions that you hear from Dr. Yung, feel free to type your answers in the chat or just think on your own as to what the answer might be for the question. But I do have some reminders for y'all, especially if you are new to virtual shadowing, if this is the first time you've joined in on one of our sessions. Towards the end of each of these sessions, we do have a Q&A. And that Q&A is reserved for any questions about the specialty, about the speaker. Any questions that you have, feel free to type them in the chat as we go, and we will read those out at the very end. I read them out in the order that we receive them, and usually we're able to get to all of them. And then another reminder, my last one, is about how you can stay tuned with other virtual shadowing sessions that we have coming your way. So we do have these sessions on Mondays and Thursdays at 7 p.m. Central. That's our typical timing, although there are some changes that we might have along the way. So for any changes, for any different days, different times, you can stay up to date with that through our email listserv or through our Instagram page. On both of them, we do have flyers, so you'll receive the same content, but there are just two ways to go about it. So our email listserv is sent out weekly on Thursdays. It does have a couple other opportunities because we do have a mentorship program, we do have volunteering programs. If y'all want to hear about that, I really do recommend that y'all join our email listserv. And to do that, you can either email us at community@hearts4health.org, or you can go onto our website. We have a subscription form at the very bottom of every one of our pages. Fill out that subscription form with your name and your email, and you'll be on the listserv. And then our Instagram, you can feel free to follow our Instagram. Again, we just post flyers there, mainly for shadowing sessions, but we do have a few other flyers for other opportunities as well. That's all I have to say in terms of reminders. If y'all have any questions about what I just said, feel free to shoot us an email, shoot us a DM over Instagram, and we're happy to answer any questions. But with that said, Dr. Yung, feel free to take it away.
Yeah, hi, I'm Madeline Yung. I'm one of the cataract refractive specialists at UCSF, and I'm very privileged to have the help of Irene Pack, who is a rising second-year medical student at UCSF. We hope during this presentation we can convince you that ophthalmology is the best specialty and a career you should definitely consider. So I'm going to share my slides here. Okay, Michael, that looks okay?
Perfect.
All right, thank you. So we're going to be talking today about ophthalmology. Think to yourself here, what is ophthalmology? The first time I heard this word, I wasn't even sure that I knew how to spell it. We have a joke that in order to get into the specialty, you have to learn how many T's and how many H's are actually in this word. Ophthalmology is the medical and surgical treatment of eye disease. This is a little bit different from optometry, which we often get confused with. Optometry, professionals go to optometry school as opposed to medical school, and they typically work with glasses, contact prescriptions, and do basic screening, whereas ophthalmology really focuses on medical and surgical treatment. So today we're going to be talking about three major topics. We want to tell you why ophthalmology is awesome. Then we're going to get into a little bit on how the eye works so that you have the background to understand some cool eye cases. So why is ophthalmology awesome? Think about the activities that we need our eyes for. There are some studies that show that loss of vision is one of the greatest fears that people may have, second to public speaking. Vision is very important for getting around. Imagine what it would be like if you woke up in the morning, but had to do all of your morning routine without being able to see. How would you get to school? How would you study, drive, get around? So there are many different things that we wouldn't be able to do if we are blind. And so it's very rewarding for an eye doctor to be able to save or restore vision to someone who is otherwise disabled. So what does my job currently entail? So I typically in a single week have 3 days of clinic where I go to a outpatient building and have patients who drive in and then go home at the same day. This is as opposed to inpatient where patients stay overnight in the hospital. And during clinic, I'll typically see 25, 30 patients in a full day, and I'll be evaluating them for a variety of ocular conditions. Some of these people that I see in clinic will need surgical treatment. So I will spend 1 day a week on average in the operating room performing different types of eye surgery that we'll later get into. And because I work at UCSF, which is an academic institution, I also spend approximately 1 day teaching residents and medical students. So how did I get here? My humble beginnings started in California at Foothill High School, home to the Falcons. And then I did most of my training at UCLA, go Bruins. I majored in neuroscience and then got my MD at UCLA, did ophthalmology residency, which is 4 years, and then 1 additional year for cornea fellowship so that I could do refractive surgery like LASIK and PRK. And I would like Irene to share a little bit about her own journey since she is a little bit closer to the pre-health stage. And Irene, take it away.
Great, thank you, Dr. Young. Hi, everyone. I'm super duper happy to be here with y'all today. This slide is meant to just give you an idea of what my pre-med journey through college looked like. To give a little bit of background, I went to college at Yale University and I majored in ecology and evolutionary biology. This timeline is to give you guys an idea of the courses that I took throughout the 4 years of college and what I got to do in the summers in between. So first year, I took half a year of general biology, 1 year of general chemistry with lab, half a year of calculus, 1 year of English, and 1 year of Spanish. Then that summer, I had an opportunity to do a research fellowship on campus, and that was a really exciting experience. Then second year, I took half a year of general biology and lab, 1 year of organic chemistry and lab, half a year of stats, and half a year of psychology. Then that summer, that was when we were early in the COVID pandemic, and so I spent a lot of my time and energy helping distribute PPE to nursing homes because at the time they were being overlooked by the healthcare system during the PPE shortage. And at the same time, I got a chance to work as an undergrad biology TA with my school. Third year, I took half a year of biochemistry, 1 year of physics and lab, and half a year of biolab. And then I took the MCAT, and that summer I did another research fellowship and then applied to medical school. And then when fourth year rolled around, that fall was full of medical school interviews, and my pre-med journey sort of ended when I finally got some acceptances after that fall semester. So I know this is a lot of words, and keep in mind, we color-coded them on purpose. The bold red courses are the ones that are normally required for all medical school admissions processes. But we want you to know that different medical schools have different course requirements. And so the green courses are the optional some schools will recommend them, but don't worry too much about all the words on the screen. In general, most medical schools, if not all, will require at least 1 year of general biology with lab, 2 years of chemistry with lab, including biochemistry, 1 year of physics and lab, and 1 year of English. And the rest, I'd recommend that, look at the medical schools that you're interested in applying to and look at their course requirements to make sure that your schedule is aligned with theirs. And also don't worry, you don't need to take them in the order that I did. There are many different permutations of pre-med courses that you can take throughout college. And at the bottom there, I just wanted to highlight some of the extracurricular activities that was most meaningful to me in college and that I ended up highlighting the most in my medical school application. One being healthcare hackathons. I went into college with a background in robotics and was growing up wanted to be an engineer, and so tech innovation was a really important to me. And so I engaged in that sphere continuously by attending healthcare hackathons throughout college. And that's actually one of the reasons why I love ophthalmology. Ophthalmology is a field where there's a lot of tech innovation happening. And it's just a really exciting and innovative specialty. I also spent a lot of time volunteering at the hospice, community clinic, and nursing home. You do not need to volunteer at that many sites. I just really enjoy service because it gave me a purpose and a really huge motivational factor into medicine. But and that's why I actively sought out to do community service, but you do not need to do 3 sites at all to get into medical school. So don't worry about that. And one other thing is I got to be a biology peer tutor through my school, and I got to learn a lot, interact a lot, and teach undergraduate students like you all, which was a really rewarding experience.
Thank you so much, Irene. All right, so I have an ophthalmology pros and cons list to try to clarify the ups and downs of ophthalmology a little bit more. So pros is you get to have a longitudinal relationship with patients. What does this mean? You can have a patient that is with you for the entire career. They might have an eye condition that needs to be monitored every year, every couple of months, and you can get to be really good friends with them, get invited to their weddings, get to know their children, relatives, etc. It's also really nice to be the expert. Your word, when you make a decision clinically, is just taken as, the truth by other professions. They don't question you. Whereas if you are not necessarily an expert, but are working as a jack of all trades, you might be needing to rely on the expert opinion and really ask someone what to do when a patient asks you what to do. I love, love, love working with my hands. And so exclamation mark after surgery, enough said. One great thing about ophthalmology is that it's very hard to kill a patient through their eyes, no matter what the horror movies might show us. Your patients tend to not die, and it's kind of nice to not have that stress in the back of your mind. But on the flip side, vision is really important to patients. So on one hand, it's very difficult to kill them, but those patients are very grateful to you because you're really guiding them through something that is very scary if they have an eye disease. Residency is not that long. It's 4 years. Yes, that seems long, I know. But if you want to go into a surgical specialty, it's actually one of the shortest surgical specialties that are out there. General surgeons, neurosurgeons, they can be in residency for up to 7 years. But it's a pretty chill professional culture. People tend to be nice, warm, welcoming. And that's probably because we enjoy a good work-life balance. When you're in clinic on the weekends, you go home, you don't have to be on call in the hospital. And then I personally think eyeballs are very pretty. Here are some pictures on this slide of the front and back of the eye. And I think it's really just one of the most beautiful structures in the body. One of the cons is that you only know about eyeballs. So if your family member asks you about the swelling of their big toe, you're going to say, well, I'm not a real doctor. Go ask someone who actually knows about the rest of the body. The other con is that no one else knows about eyeballs. So anytime an eye feels itchy or red, the other doctors are going to ask you what to do, and that can get kind of annoying sometimes. This may not seem like a big deal. Sometimes people think that you are an optometrist, and you might be taking your time to have to clarify, no, like those people go to optometry school, I'm a doctor, I'm an eye surgeon, etc. Whereas, if you say I'm a cardiologist, everyone pretty much knows what you do. And then some people think that eyeballs are gross. So there's the flip side of the relationship. All right. So I just wanted to emphasize along the way that medicine can be really fun. It can be very tiring, but you meet a lot of great similarly minded people along the way. And if you enjoy what you do, it's very difficult to regret your choice to join, this community that has a lot of purpose and is extremely rewarding. So let's go a little bit into how the eye works. So here is a picture of the eye. You have on the left a picture of the eye looking straight on. And on the right, you have a cross section of the eye. The white part of the eye is called the conjunctiva and the sclera. Then you have this top layer of the eye right in the middle that is transparent. This is called the cornea, and we don't usually see it. And that's because it is totally clear. It's like a windshield looking into the eye. Underneath that is another structure called the iris. It is the colored part of the eye, as evidenced by that red arrow. Next, we have a hole in the middle, which you'll know as the pupil. This is a hole that allows light to enter into the eye so that we can see. Behind the pupil is a structure that people usually don't know about. It's called the lens of the eye. It's also a clear structure. And if it's not clear, then light can't actually get inside of the eye. You can see that the lens is located right smack dab in the center of the vision. This lens is important because it helps focus the light into a clear picture for us to see. On the inside of the eye, we have something called the retina. This is a layer of the eye that acts like the film in a camera. It captures light so that it can create a clear picture for us to see. And then here we have the nerve. The nerve is located in the retina, and it's a collection of all of the fibers of the retina going into one area, like a TV cable, so that it can leave the eye and bring that vision signal to the brain. So here is a summary of how the eye works. You have on the left an image, a picture of the sun, for example, in this case, and light will enter as those purple rays going inside of the eye. It will pass through some clear structures like the cornea and the lens. It'll pass through the hole called the pupil, and so it gets inside of the eye. The cornea and the lens are clear and curved structures that bend the light into a good focus. And so they focus all of those light rays into one single image that then hits the retina. And that light image is then converted into nerve information, neuronal information that is then transmitted to the optic nerve to give our brain a picture. And so that's how we can see. All right, we're going to move forward to some cool eye cases, which Irene is going to very gracefully show us. I'm going to stop sharing my screen for her to take over.
Okay, great. Can y'all see my my screen?
Perfect.
Perfect, thank you. Okay, so as Dr. Young mentioned, we're just going to go into some really cool eye cases. For each case, I will present what the patient's signs and symptoms in the clinic are, and then I'll follow that with some physical exam like eye imaging that we do to observe the patient's eye, and then I'll follow that with a diagnosis for the patient and treatments that are associated with each diagnosis. All right, let's get started. All right, so this is our first patient, patient A. Patient A is a 43-year-old male who presents with pain and redness in both eyes. And when he was 8 years old, he had smoke from a Chevron refinery fire get into his eyes. And he's been continuously exposed to weed smoke at home. So when we look at his eyes a little closer under the slit lamp, and to give you a little bit of background, a slit lamp is a microscope that ophthalmologists use to visualize different components of the eye. And for each of these slides where I show you the patient's eye up close, I will always have a normal eye on the left and the patient's eye on the right. And in this case, both eyes are looking up. When we ask the patient to look to, again, this is their right eye, so when we ask the patient to look to the left, this is what it looks like. And when we ask them to look to the right, this is what it looks like. And this is where I wanted to ask if anyone could tell me what differences they notice between the normal eye and the right eye. I'll give you a second to think about that. So you may have noted that from the get-go, you notice that the patient's eye is a lot redder than the normal eye. And that redness is due to a lot of inflammation going on in the eye. You also might have noted that the cornea looks a bit cloudier, and that cloudiness is due to corneal scarring. It's also worth noting that this patient's eyelid is a lot more inflamed than the normal eye, as in it's a lot thicker. The eyelid's a lot thicker than the eyelid you can see in the normal eye. And someone might have noted, oh, there seem to be, these folds on the conjunctiva that you wouldn't see normally when you ask a patient to look in a normal person to look in that direction. So I want to direct your attention to sort of this bottom right corner of the patient's eye. It's really hard to distinguish the margin between the eyelid and the eyeball. Much harder than, let's look at this normal eye, where it's very clear that this is where the eyelid ends and this is where the eyeball begins. That inability to distinguish that margin indicates that there are these abnormal adhesions forming between the eyelid and the eyeball. And therefore, when you ask a patient to move their eyeball to a certain direction, those adhesions are being pulled and they form these folds on top of the conjunctiva. So those adhesions are characteristic of a condition that we call symblepharin. So symblepharin, again, is an abnormal adhesion between the eyelid and the eyeball, and it can be caused due to damage to the conjunctiva. So if you remember from what Dr. Yung just told us, the conjunctiva is the outermost membranous layer between the eyelid and the eyeball. And there are multiple reasons why you could get damage to this structure. One could be a chemical burn. So if your eye is exposed to a chemical, it can cause damage, and we call that a chemical burn. And one of the examples of how you can get a chemical burn is through an exposure to smoke. And hopefully that rings a bell for y'all, because if you remember, this patient came in with a history of being exposed to smoke from a refinery fire and constant smoke at home. There are also, you can get damage to the conjunctiva through a thermal burn, like being exposed to fire, infection, etc. There are different multiple ways, but the one we wanted to focus on was chemical burn, because that's the one that most likely had caused the symblepharin in this patient. Some of the consequences of having symblepharin is patients can develop dry eyes. So that initial injury that caused damage to the conjunctiva and led to those adhesions most likely caused damage to other structures in that area, including the glands in the eyelid that form oils and tears that help keep your eye lubricated. But now without those structures, the patient is a lot more susceptible to developing dry eyes. And remember, symblepharin is an adhesion between the eyelid and the eyeball, which means there is tissue tugging at both structures. And so when it's tugging against the eyeball, you see a restriction in eye movement, and the patient can't turn their eyeball completely in certain directions. And because the tissue is also tugging at the eyelid, the patients are unable to close their eye completely. So what are some treatments for symblepharin? Firstly, we always try to reduce the inflammation with medications. And the reason why is when there is damage that occurs to the eye, our immune system responds to that damage by causing inflammation. And that inflammation leads to the formation of scar tissue that form these adhesions and make up symblepharon. And so we want to try and reduce that inflammation to reduce the formation of those adhesions. And we do that using medications like steroids and anti-inflammatories. And I mentioned earlier that patients with symblepharon are also more susceptible to developing dry eyes. So we want to try and help keep their eyes lubricated by using artificial tears and ointments. There's also a surgical treatment for symblepharon. It's a reconstructive surgery, and we can see that on the right diagram here, where the left column is a patient's eyeballs before the surgery, and the right column, did I say that correctly? Left column is before and right column is after. So you can see in the eyeballs of the patients before surgery, you see the characteristic adhesions between the eyelid and the eyeball. Then after, during surgery, they remove these adhesions and reconstruct the areas that the adhesions used to be, so that it almost looks like a normal eyelid and a normal eyeball. That's what we call conjunctival reconstruction here. That's what we're referring to. For this patient, just to wrap up his story, this patient is currently on medications to reduce inflammation and increase lubrication, and is waiting on reconstructive surgery for his symblepharon. But even with just the top two categories, his vision has improved from 2100 to 2050. And just to give you an idea of what the numbering system for vision looks like in ophthalmology, 2020 is, I'm sure many of you have heard, perfect vision. That means that someone can see an object from 20 feet that any other person can see at 20 feet. But when that denominator gets bigger and bigger, that indicates that their vision is worse. So for example, for this patient started off with 2100. That means that what other people can see at 100 feet, this patient has to see at 20. As you can see here, their vision went from 2100 to 2050. So the denominator decreased, which means their vision improved. I had opportunities for questions at the end of each case, but given the whole YouTube format, I will just wait till the very end of the presentation, and people can ask questions about cases then. So moving on to the second patient, patient B. Patient B is a 43-year-old male who is presenting with a severe loss of vision out of his right eye. He can only detect hand motion. And what that basically means is, I just told you about the numbering system for vision in ophthalmology. Oops, sorry. And sometimes, and you might recognize that from when you've been to an ophthalmologist and maybe gotten glasses, they've had you sit at a certain distance from a chart and read out any letters or numbers that you can make out. There are some patients who cannot read even the largest letter or number on that chart. And when they can't read that, we have other tests to see, to try and see how poor their vision is. After that largest letter, what we move on to is something called counting fingers. We will hold our hand in front of their face at varying distances and ask if the patient can tell us how many fingers we're holding up. If they can't distinguish the fingers, then we'll move on to hand motion detection. We'll move our hand in front of their faces and ask if they can detect any hand movement. So this patient, that goes to show how severe this patient's loss of vision is, because this man can only detect hand motion. And on further lab testing, we found out that he tested positive for herpes simplex virus, also known as HSV. I'm curious to know what words come to people's mind when they hear the word herpes. But in general, when people think of herpes, they tend to think of the sexually transmitted form of herpes, and that is herpes virus type 2. This one primarily infects the genitals and is also known as genital herpes and is the sexually transmitted form. But the virus that causes ocular disease actually is not type 2. It's HSV type 1, which primarily infects the face and is also known as oral herpes because it causes cold sores around the mouth. And this type of herpes virus is the most common cause of an ocular condition called keratitis. So this is the type that we'll be focusing on for this patient. So what is keratitis, you might ask? So keratitis is the inflammation of the cornea. And when that inflammation is caused by an HSV infection, we call that condition HSV keratitis. And just as a reminder, the cornea is that outer, I'm not sure if you can see my mouse, but that outer transparent layer at the front of the eye. And what's happening is due to that infection, the immune system of the patient is responding by sending inflammatory cells to the area of infection. And when those inflammatory cells migrate and accumulate within the cornea, we see them as this clouding under the slit lamp. And we will also see blood vessels form around and into the cornea that allows the migration of white blood cells into the cornea, which we should not see in a normal patient. Some of the consequences of this really robust inflammatory response is the infection will start eating away at the cornea, and that will lead to the thinning of the cornea and a condition we call corneal melt. And when that thinning becomes severe enough and the infection eats away at the tissue severely enough, will form a hole in the cornea, and that condition is called a corneal perforation. So when we look at the patient's eye under the slit lamp, again, here is a normal eye anatomy on the left and the patient's eye on the right. This is where I would normally ask you what abnormalities you notice between the patient's eye and the normal eye. And I'll just give you a second to think about that real quick. So you might have noticed that there's quite a bit of clouding in the cornea, in the patient's cornea. And again, that's a result of inflammatory cells migrating into the cornea of the patient in response to the infection. And those inflammatory cells are seen under the slit lamp as this clouding over the cornea. Associated with that, you may have noticed, if you look really closely, there are these blood vessels around the cornea that are starting to, you can see the ends of it going into the cornea. And that's because these blood vessels are the venues through which the white blood cells in response to the infection are traveling into the cornea. And you'll notice that there's this hole in the center of the patient's cornea. That hole is what we were talking about earlier. When the infection gets severe enough and causes thinning of the cornea, also known as corneal melt, that thinning can get so severe enough and the infection can eat away the tissue so severely that you just form a hole. And that hole is called a corneal perforation. Okay. What are treatments for this condition, HSV keratitis? So any condition that is caused due to an infection, we always try to use medications to treat that infection. So for patients with HSV, because HSV is a virus, we try to use antiviral medications like acyclovir to treat the HSV infection. And with patients with corneal perforation, there are two things that we can do for them. One is we use this glue to sort of fill in the hole and try to stabilize the eye. And if that doesn't work, the next form of treatment involves surgery, specifically corneal transplant surgery. And what that involves is basically you remove the damaged cornea from the patient's eye, and then you replace it with a healthy cornea from a donor, and then you tie it down with sutures on the patient's eye. Okay, so on the next slide, this is going to show you a video of exactly what I just talked about, corneal transplant surgery. This one in specific is called penetrating keratoplasty, but you don't need to worry about the name. And I'm going to try and narrate it. I might pause the video here and there to try and explain to you what's going on in the video. So at the beginning, they're just preparing the eye for surgery, and you'll notice this stabilization ring that is being used to just stabilize the eye so that it doesn't move around too much during surgery. Okay, and then they are going to make a small incision at the intersection between the cornea and the sclera, and that will give them access to the inside of the eye. Okay, oh no, sorry, let me go back. All right, and then once the incision has been made, they will inject a fluid called Healon, which basically what that does is prevents the cornea from deflating. Then they're going to use this device called a trephine to cut out a circular section into the cornea around halfway deep. And they'll use this radial marker to then mark out where the sutures will go at the end of the surgery. Then they're going to go inside the eye and try and fully cut out that circular section with these special scissors that have curved blades. Okay, and they'll get rid of the old cornea and we'll replace it with a new healthy cornea from a donor. That's the donor cornea. And now they're going to secure it into place by making sutures all around the donor cornea. And by the end of this procedure, there will be 16 sutures all around the cornea. Okay, the last step is just burying the knots, and that's what the patient's eye looks like by the end of the transplant surgery. All right, so this patient ended up undergoing corneal transplant surgery because, again, they had this corneal perforation, and I just wanted to show you the results of their surgery, which is really successful. So on the left is the image of the patient's eye before surgery, and on the right is the image of the patient's eye after surgery. If you remember, there was clouding and this hole for the patient before surgery. Now, if you look at their cornea, it's nice and clear. There's no clouding, no hole. This is a new healthy cornea from the donor. And we can sometimes look at the patient's eye under blue light. And what we do is we stain the eye with a dye that specifically highlights any abnormalities on the surface of the cornea. And this is a good sign because we don't see any highlighted areas in the cornea, which means it's nice and clear, no abnormalities. And it also outlines the sutures, the 16 sutures that have been placed to keep the donor cornea in place. After the surgery, the patient had a significant improvement in vision. If you recall, this patient started off with vision only being able to detect hand motion in front of their face. And after this surgery, their vision improved to the point where they could see 2100 with glasses. You might think 2100, that's still a ways off from 2020. But for this patient, that's still a really significant improvement because, again, all they could detect was whether a hand was moving in front of their face or not. And now they can distinguish letters and read them. So it's a really big change. Okay. Moving on to the next patient, patient C. Patient C is a 71-year-old female who has blurry vision out of her right eye. If you remember, counting fingers is the test that we do before we go to hand motion detection. So this patient could only count fingers from 4 inches away from her face. So still very, very blurry vision. When we look at her eye under slit lamp, again, the normal eye is on the left and the patient's eye is on the right. I'll give you a second to think about what the abnormalities you notice are for the patient. You probably noted that there's a lot of clouding in the center of the eye. And that's exactly what we wanted you to notice for this patient. And The next question that I had was, I was wondering if any of you could guess which part of the eye that clouding is affecting. And as a hint, you can see the cornea is nice and clear and the iris is nice and intact and fully there. So that means that this clouding is affecting a structure that's behind the iris. I'll give you a second to think back to what Dr. Yung talked about, the eye anatomy, and which part of the eye that clouding might be affecting then. Hopefully you said the lens. When there's a clouding of the lens, we call that a cataract. And just to help you visualize that in this cross-sectional diagram, again, we saw the cornea was nice and clear and intact iris and pupil, and behind that structure is what we would see the lens in. And Dr. Yung mentioned that this needs to be clear so that light rays can be filtered through and the patient can see. But when there's clouding like this, it impedes vision, and we call that condition a cataract. The most common cause of cataracts is aging, because by starting around age 40, the natural proteins in your lens start to break down and clump together and form these cataracts. By age 65, more than 90% of the people in the US will develop cataracts. So it unfortunately is a very common condition, but fortunately, we have a really effective treatment for patients with cataracts. The treatment for cataracts involves cataract removal surgery, where we basically will replace the cloudy lens with a new one. And this diagram highlights the 4 main steps in this surgery. First, you make an incision, and then you break up the cloudy lens inside this supportive bag that is holding the lens in place, and that process is called emulsification. And then once you break them up into little pieces, you suck up the little pieces out of the bag, and then you implant a new intraocular lens into that supporting compartment. And there you have it. You have a new lens sitting in place, and the incision will heal on its own. This is a animated video that will show you exactly what I talked about on how a cataract removal surgery works. This one has narrations, so I'll just let you listen to it.
Before the procedure, the surgeon numbs the area with anesthesia. Pressure may also be applied to decrease the internal pressure within the eye. This will lower the chances of complications later in the surgery. Then a small incision is made in the cornea of the eye. Fluids are injected into this incision to support the surrounding structures. The top of the lens capsule is then removed to gain access to the cataract. The surgeon then uses ultrasonic waves to fragment and emulsify the clouded portions of the lens. They are then removed. Once the cataract is removed, an intraocular lens, or IOL, will be placed into the empty lens capsule. Small struts will hold it in place. Once properly positioned, the synthetic IOL restores the patient's vision.
Right, so it's a really cool surgery, and it's very rewarding. Cataract removal surgery, this patient ended up going through cataract removal surgery, and these are the results. This is, again, the photo of the patient's eye before surgery, and this is after. And you can automatically tell that that clouding that was at the center of the eye is now gone. And it was replaced with a nice clear lens that allows you to see the pupil clearly and see through to the back of the eye. Vision also significantly improved for the patient. If you remember, she started off with only being able to count fingers at 4 inches from her face. And after the surgery, her vision was restored to 20/20, aka perfect vision. So this surgery is an extremely, extremely rewarding surgery, because a lot of patients walk in with these cataracts that prevent a lot of their vision. And then, immediately after the surgery, they can see through their lens now, and their vision has significantly improved. But I mentioned that for this surgery in particular, the lens is emulsified, broken down, and sucked up and removed, but we leave the supportive compartment or bag there because that is what holds the lens in place. What if that compartment that's supposed to hold the lens is unstable? Then what do we do for patients like that who come to us with cataracts? That leads me to the next patient, patient D, who is a 51-year-old male who had a rock thrown into his right eye when he was 7 years old, and he's had poor vision in that eye ever since. And when he presented to clinic, he could only detect hand motion out of that eye. When we look at his eye under the slit lamp, we see, again, this is normal, and this is the patient's eye. I'll give you a second to think about what the abnormalities are that you notice. Hopefully most of you guys noticed that, again, there's this clouding in the center of the eye, and that clouding most likely has to do with a cataract. But one additional thing that I was hoping that you would notice is on the right side, there's this black crescent. And that black crescent indicates that this cataract, this lens is off center. And because it's off center, it's leaving behind this black crescent where that space should technically be filled by the lens if it were held properly in place. So what that means is the supporting structures that are supposed to keep the lens at the center is probably missing or damaged. And so in cases like this, we can't do the cataract surgery that we did for the previous patient where you just leave the supporting compartment there and then remove the lens because there's something wrong with that supportive compartment. So what do I mean by those supporting compartment or structures? There are two main structures that I wanted to bring your attention to for this patient. One is something called zonules. Zonules are these thread-like fibers that attach the lens to the sides of the eye and keep the lens in place. These zonules also work with the muscles on the side of your eye to sort of stretch and relax the lens and to help you adjust focus. But for the purposes of this patient, all you need to know is these zonules help keep the lens attached, connected, and in place. The second supportive structure that I wanted to discuss is called the capsule. The capsule is like the membrane that surrounds the lens. And so it acts like almost like a supportive bag that holds the lens in place. For this patient, if you recall, when he was 7 years old, he had a rock thrown into his eye. And that physical trauma led to damage to his zonules and his capsule. And so now these supportive structures that are supposed to hold the lens in place are now missing. So we need to think of a different surgery for this patient to remove their cataract. So this patient's cataract removal surgery is a bit different in that for him, we're going to remove the entire lens, including the surrounding compartment that is damaged. Once we remove that entire lens, we're going to replace it with a new intraocular lens and secure that lens in place using these two stabilization arms that extend out of the sides of the lens. And these arms will fasten onto the sclera and help secure the lens in place. This specific type of cataract removal surgery is required in patients who have zonules that are extremely unstable or have damage to their capsule, both of which apply to our patient. So this is another video of the cataract removal surgery that I was just talking about. This one doesn't have any narration, so I'll try and narrate the steps to you. So at the beginning, they're holding open the eye with this with this device called a speculum, and they're going to make a large incision again at the intersection of the cornea and the sclera. This incision is going to be larger than the incision we made for the previous patient, because for this patient we need to remove the entire lens, so that requires a larger space. Okay, then they're going to go in with a probe to then scoop out the entire cataract along with the capsule surrounding it. It's really satisfying to watch the cataract come out. And then they're going to implant a new intraocular lens. And then once they do, they're going to use a needle and stick a needle through the white sclera to gain access to the inside of the eye. And once they do, they're going to use these micro forceps to grab the stabilization arm and insert it into the lumen of the needle. Okay, and they're going to do the exact same thing for the other arm. Remember, an intraocular lens has two stabilization arms extending out. Okay, and once they do this, they're going to pull out the needle out above the surface of the sclera with the stabilization arm with it. And this will allow us to fasten the extension or the stabilization arms to the conjunctiva. And this is what helps keep the intraocular lens in place. So this is what the final result of the surgery looks like. So for this patient underwent this cataract removal surgery, and these are the before and after results. So before, again, he had this cloudy cataract that was off center and left this black crescent on the side. Afterwards, you see this nice, clear, beautiful intraocular lens that has been implanted, and you see the two stabilization arms extending out and holding it in place. Vision was also significantly improved. If you remember, this patient started off with only being able to detect hand motion, and afterwards his vision improved to 20/125. All right, last patient.
It's almost 6, so I don't know if we'll have time to do the last case. Michael, do we usually have time to go over a little bit, or should we move on to Q&A at this point?
Yeah, so we don't typically have it fixed 7 hours. So if y'all want to just go through this last case, and we can have just a little bit of a shorter Q&A, but we can save a couple of questions still. If y'all don't mind, we can still go over by a little.
Okay, perfect. Just making sure.
Okay, I'll go quickly through this one. So this is our patient E, who is a 57-year-old female presenting with blurry vision out of her left eye. She can barely count fingers at 2 feet. And on slit lamp exam of her conjunctiva, cornea, and lens, everything seems normal. So this is where I wanted to give you an opportunity to think about, okay, what structure of the eye must be wrong then? And to give you a hint, you could probably do process of elimination to figure out which structure is left of the ones that Dr. Yung talked about. It's the one behind the lens. Hopefully, you guys were able to say retina. This patient, most likely, given that the conjunctiva, cornea, and lens are normal, most likely has something wrong with her retina. And so we take an image of the patient's retina. On the left, we see a normal retinal image. You might remember the optic nerve that Dr. Yung talked about. That's this bright yellow circle off to the center here. And then from it, we see these blood vessels emanating, and these bring oxygen and nutrients to the rest of the retina. This is the patient's image of, or the image of the patient's retina. hopefully you notice that there is this gigantic black area to the right side here that should not be there. That black area is an indication that the retina has detached. So what does that mean? Retinal detachment is a condition that occurs when the retina is pulled away from its normal position at the back of the eye. And the most common cause of this is retinal tear. If you see in the photo on the right, there is this retinal tear, and when this retinal tear occurs, this allows fluid. I said vitreous fluid here. It's labeled as vitreous humor here. It can also be referred to as vitreous gel. All you need to know is that there's this gel-like fluid that fills the back portion of the eye here. And when there's a tear on the retina, this fluid can seep through and collect underneath the retina, causing it to become detached. So what is the treatment for patients with retinal detachment? This one also involves surgery, a surgery called vitrectomy. And what happens during vitrectomies is we remove the vitreous gel that was originally there, making sure to fully separate it from the retina. And then we flatten out the retina by, one, we want to make sure we remove all the fluid that accumulated underneath the retina and caused the detachment in the first place. And then two, we want to push against the retina by replacing that original vitreous gel with some sort of heavy fluid or a gas bubble. And that will, again, push the retina against the back of the eye and flatten it. Then we want to make sure that none of that new fluid or gas seeps under the retinal tear again and cause another detachment. So we use a laser to tack down the sides of the retinal tear and make sure that the fluid or gas can't seep through. Gosh, that keeps happening, sorry. And here are the results for the patient after she went through a vitrectomy. If you remember, this is the image of the patient's retina before the surgery, and this is after. Before, there was this really huge black portion of the retina that had detached from the back of the patient's eye, and here the retina is nicely attached back to the back of her eye. And if some of you may notice that there's this sort of yellow blotch at the upper right corner of the image, and that blotch is most likely remnants of the lasering that was used to tack on the retinal tear back to the back of the eye to prevent any fluid or gas from seeping in and causing another detachment. This patient also had significant improvement in vision. She started off counting fingers at 2 feet, and with the surgery, her vision improved to 20/300. All right, so these are some take-home points. Dr. Yung, I'm not sure if you want to chime in and go over them because I've been blabbering for the past for too long.
No, you've done an amazing job. I couldn't have done it better myself. But we hope that with this presentation, you can take home the points that ophthalmology is a really awesome specialty with a great mix of clinic, surgery, but also a good work-life balance. We have a lot of different parts of the eye that we talked about today, including the white part, the conjunctiva and the sclera, the front clear part called the cornea, the colored circle called the iris with a pupil hole in the middle, the lens resting behind that, and finally, the back of the eye, which is covered by a wallpaper like the retina, taking visual information to the brain via the optic nerve. With correct medical or surgical treatment, we can help patients with severe disease regain vision, which is incredibly rewarding. All right, so are we moving to the Q&A at this time?
Yeah, let's have just a few questions for the Q&A. It might be a little shorter, but we'll definitely cover some questions. If y'all don't mind, I can kind of alternate between Dr. Yung and Irene. We can kind of switch up with questions, but like I said, we won't probably have too many questions for this Q&A. So just to start us off, we'll have one question for you, Dr. Yung. You mentioned that you're a subspecialist, right, in ophthalmology. How did you reach the point of deciding what that fellowship would be, what that subspecialty would be? And along with that, what are the other subspecialties that an ophthalmologist can choose out of residency?
Yeah, great question. Let me back up a little bit and talk about choosing ophthalmology from medical school. During medical school, you do have the opportunity to rotate through different types of specialties. And so you get exposure to what you like, what you don't like. I initially joined medical school thinking I was going to be a pediatrician. And then I went to a pediatrics clinic and I was like, oh, they cry a lot and I can't get them to stop. This is not for me. So in terms of choosing my fellowship, I did a lot of rotations during my first and second years of ophthalmology residency. And I found that I really liked how with cataract surgery or with LASIK, you can bring patients with not great vision at all to 20/20. I found that extremely rewarding. And it was like trying to get, shooting hoops 100% of the time. Like that is something that I'm always striving towards is perfection. So that's how I decided on my fellowship. It's kind of insane how many different subspecialties there are for such a tiny little part of the body. But besides cornea, we have subspecialties for neuro-ophthalmology or the nerve of the eye, retinal specialists, eyelid surgeons, otherwise known as oculoplastics. We have subspecialists for inflammation of the eye, so uveitis is the medical term for that. And there is a single disease that actually has its own fellowship called glaucoma. So many different types of subspecialties available in ophthalmology.
Great to hear. It seems like these subspecialties have really been evolving quite rapidly over the past few years. We've been actually on that same topic for at least the past 2 sessions, how subspecialties have been evolving so rapidly. We have another question for you, Irene. This one is about how y'all mentioned there's ophthalmologists and there's optometrists. Is there collaboration between the two professions? Do you see that?
Yes, there's definitely collaboration. And actually, Dr. Young can probably speak more to that because she works in the clinic here. But I've been in clinic multiple times now, and they work hand in hand to help coordinate patient care. Dr. Young, if you want to add on to that.
I would say that optometrists are really frontline for medical disease, and they work in the community and will often see many different patients and be able to handle a lot of the basic medical treatments. But patients who have more complex disease or require procedures or surgery, then they will refer them to an ophthalmologist. So it really is a team effort.
We also know that there's some conditions that kind of come with cataracts or that come with having cataracts in general. What percentage of patients have those like comorbidities? Dr. Young, can you answer that?
Comorbidities with cataracts, that's a really good question. I guess the biggest comorbidity, and I wouldn't really say that this is a disease, is age. So most of the patients who come into with cataracts are older. Cataracts can be associated with systemic comorbidities, meaning that something besides age has caused the proteins to clump up and that lens to become cloudy. And so anything that causes an insult to the lens like that can cause cataracts. Sometimes babies have cataracts. Medications like steroid usage can cause cataract formation. Sun exposure, smoking, alcohol use, other oxidizing stresses can be associated with cataracts as well.
All right. And Irene, you mentioned that you were involved in engineering, right? You like the innovative side of ophthalmology. So we actually have a question about that. What are some new innovations that are or can at least cure blindness? Are they out there?
I think ophthalmology being a surgical specialty already allows for a lot of involvement in tech innovation. And a lot of people, when they think of healthcare innovation, think of diagnostic tools or surgical tools, but at least some of the ophthalmologists I've met here at UCSF are working on some really cool patient technology that tries to bridge disparities in healthcare outcomes. So there are many different ways in which technology is used to improve ophthalmic care for patients. In terms of curing blindness, I'm not sure. I don't think yet, but it is honestly such a rapidly evolving field. So it's something that we're all, I guess, looking forward to in the future, hopefully.
I can speak a little bit to that. So in the field of cataract surgery, the main technological push is getting people to see better after cataract surgery. So before, we were just trying to get that cloudy lens out of the eye, but patients might not necessarily have good vision afterwards. But now a lot of patients are saying, wow, I have never seen this good in my entire life. We're able to get rid of glasses and have patients have 20/20 or better vision if they have a good eye or good healthy eye otherwise to start with. Another really fun thing that's happening right now is that people are working a lot with stem cells, and they're growing parts of the eyes in labs that can then be transplanted into the eye. And some of these new technologies are actually able to let patients be able to see things that are actually not visible to the natural human eye. This is definitely not FDA approved yet. It's in the clinical trial phase, but they have shown some studies where you can turn off the light completely in a room. And because the patient is seen in a completely different way than the natural light, they're able to take in like infrared information and follow a line out the door and navigate to that in a completely dark room.
Wow, that definitely is some innovation going on for sure. And I know UCSF has centers dedicated to innovation, so they're definitely on the front line of that. Let's go for one more round of questions. I'll start with you, Irene. Being now a med student, you've been through the whole application cycle process. A lot of the students joining us in are going through that process right now, actually, now that it's summer. So is there anything that you believe in your application stood out? And I mean, not necessarily for just UCSF, or if you want to just comment on UCSF, but because I know schools look for certain things based on mission. So in either case, whether it's that generally stood out or that stood out for your school for UCSF as to, what you believe, what are those things that, might help the students out here who are going through the application cycle?
Yeah, I also have quite a few friends this year who are applying into medical school. So this summer seems to be a stressful summer for many people. And having read quite a few personal statements at this point, I think personal statement is a really important component of the medical school application. And my biggest advice for that is to just make it personal to you. I know that there's a lot of advice out there on, there's a lot of advice, but really when it came down to it for me, I made sure to write an essay that was most representative of me and why I wanted to join medicine. And that voice, that unique voice, is really important in carrying out whatever it is you want to highlight in your application throughout the entire process. And I'm sure people are, I joke, but looking forward to all the secondaries rolling in next month. When those secondaries come around, I recommend looking at the mission statements for each of the schools that you're applying to and see how your interests, your passions align with that school's missions. Because ultimately, one of the criteria that they look at as they're sifting through applications is, how well does this student fit into our medical school environment and the class that we want to shape here.
That's very helpful to hear. I might just add on to that because it's kind of to a similar point as you mentioned. I heard one person say that the primary is representative of, or just a way for schools to see how great of a doctor you can be, and then the secondaries kind of narrow down the applicant group to see who fits the mission. So I guess two phases of things that you kind of have to tackle a little differently there. And then for our last question, Dr. Yung, I know this might be a little early for our students who are still in college, but for you entering fellowship, where I'm sure it is pretty competitive to get into a subspecialty, what do you think stood out for you when program directors were looking at your application?
I would say that the higher up you get in your training, the more it is about who you know. And letters of recommendation are more and more important, even after you graduate from training. So I would say that as you become more specialized, your community gets smaller. Med school is smaller than your college class, residency is smaller than med school, fellowship is even smaller than that. So it's just important to make sure that you are treating each person that you meet in as professional and as kind of a way as possible to make sure that you don't leave a bad impression on anyone. And people can tell when you're being a genuine and hard worker. And even though you might not think anyone is watching, that general approach of how you face your work and your career does, leave that, does affect your reputation, is what I'm saying. So I guess my main advice is that a lot of times when we're starting off early, we think a lot about our grades. And our fund of knowledge and how much we know. And we don't get as much training on how we interact with people and how we are able to maintain professional relationships. So that's something that, you want to think about and just be aware of when you're in that environment, and to, not necessarily wear the wrong outfit to work or otherwise do something that would not be work appropriate.
Some great advice to end off on. I really do appreciate both of y'all for taking the time to go through this presentation today. We love seeing the cases. We love learning about the field of ophthalmology. I think this is actually our first shadowing session. We've had over 70 now, and this is, I believe, our first on ophthalmology. So it's a great introduction to this specialty. Before we do go, though, I do have a few last reminders for our shadowers, those who are listening in. So if y'all are interested in earning credit for your attendance today, we do have a quiz. That quiz is posted in the chat box, either to the right or to the bottom of the live stream that you're looking at right now. It's also posted on our virtual shadowing page on our website and in the description of our video. So any three places, feel free to click onto the link there. It's just a Google form with 10 questions. And if you get 6 or more correct, you will pass. If you do pass, you'll receive a certificate to the inbox of the email address that you list on the quiz. We definitely recommend that you list a personal Gmail or Yahoo account or some sort of personal email address, because sometimes when you use a school address, it does filter out to spam. If you don't receive it in your inbox within the next 5 minutes or so from submitting, please do check your spam folder. But if you don't receive it in either, please do feel free to email us. Our email again is community@hearts4health.org. We're always happy to take any questions about shadowing or any of our other programs there. And and just one more thing before I move on, the quiz will be due next Wednesday, June 14th at 11:59 p.m. Central Standard Time. So just be sure to have it done by then or before then. And then for our next shadowing session, we're going to be joined by Dr. Anani. He is an emergency medicine physician who works as the medical director and chief of staff at Northcrest Emergency Department in Nashville, Tennessee. And we'll see him next week on Monday, June 12th, a regular time of 7 p.m. Central. And we'll have speakers that will be joining in the Mondays and Thursdays that follow. So definitely be sure to tune in. Like I said at the beginning, Instagram and our email listserv are 2 great ways to get in touch with us. But that's really all the reminders I have to say. Let us know if you have any questions. Let's hear some thank yous in the chat for Dr. Yung and Irene for getting this presentation together. Like I said, it was great to learn about ophthalmology. And y'all will definitely want to keep your notes on this session, or at least keep a bookmark on this session for sure later on with your MCAT if you haven't taken that yet, because there is some eye anatomy there, some eye physiology that they do include. They do test that sort of stuff nowadays with the MCAT. So definitely be sure to keep this all in mind. But other than that, that's all. Thank you again, Dr. Yung. Thank you again, Irene. And I hope y'all have a great